Hello, my name is Dr. Karen Brochet, and I'm the Associate Dean for Graduate Medical Education at Southern Illinois University School of Medicine. The impetus for change in the Accreditation Council for Graduate Medical Education was triggered by the tragic death of Libby Zion in 1984. This resulted in an explosive change in residency training and medical education based on recommendations from the Bell Commission. In 2003, to address the issue of resident fatigue, the ACGME first adopted restrictions on resident work hours, including the 80-hour work week. In 2011, the focus was on supervision, especially for junior learners. This educational module will focus on standards and elements of effective supervision that are common to all specialties. In line with the Institute of Medicine's call to build a safer health system, we're in a new era of medical education and residency training, where we're charged by the public interest with the task of providing a safer system in which to train the doctors of the future and improve the quality of care we deliver to our patients. We hope you will find this educational module useful and instructive. We will all be working together to integrate these supervision standards into our curriculum. Now, let's review what some of the important standards are. Each patient must have an identifiable attending physician who is ultimately responsible for that patient's care. This information should be available to residents, faculty members, and patients. Residents and faculty alike should inform patients of their respective roles in each patient's care. The program must demonstrate that the appropriate level of supervision is in place for all residents who care for patients. Programs must use the following classification of supervision. Direct supervision. The supervisor is physically present with the resident and the patient. Indirect supervision with direct supervision immediately available. This means the supervisor is physically within the hospital or clinic and immediately available if needed. Indirect supervision with direct supervision available. This means the supervisor may not be physically present within the hospital or clinic, but is immediately available either by phone or pager. And lastly, oversight. The supervisor provides review of patient encounters after the care is delivered. The privilege of progressive responsibility, conditional independence, and a supervisory role in patient care delegated to each resident must be assigned by the program director and faculty members. Faculty members, who function as supervisors, should delegate portions of care to residents based on the needs of the patient and the skills of the resident. Programs must set guidelines for circumstances and events in which residents must communicate with the appropriate supervisor, such as the transfer of a patient to ICU or end-of-life decisions, etc. Each resident must know the limits of his or her scope of authority and the circumstances under which he or she is permitted to act with conditional independence.